In this video we will talk how to perform primary survey in a trauma patient as per ATLS protocol. When treating injured patients, clinicians rapidly assess injuries and institute life-preserving therapy. Because timing is crucial, a systematic approach that can be rapidly and accurately applied is essential. ATLS principles guide the assessment and resuscitation of injured patients. Judgment is required to determine which procedures are necessary for individual patients. Patients are assessed, and their treatment priorities are established, based on their injuries, vital signs, and the injury mechanisms. The primary survey encompasses the ABCDE of trauma care and identifies life-threatening conditions by adhering to this sequence. 1. Airway maintenance with cervical spine stabilization. 2. Breathing and ventilation. 3. Circulation with hemorrhage control. 4. Disability, assessment of neurologic status. 5. Exposure and environmental control. During the primary survey, life-threatening conditions are identified and treated in a prioritized sequence, based on the effects of injuries on the patient's physiology. Regardless of the injury causing airway compromise, the first priority is airway management. The prioritized sequence is based on the degree of life threat. The abnormality posing the greatest threat to life is addressed first. Upon initial evaluation of a trauma patient, first assess the airway to ascertain patency. This rapid assessment for signs of airway obstruction includes inspecting for foreign bodies, identifying facial, mandibular, tracheal or laryngeal fractures and other injuries that can result in airway obstruction, and suctioning to clear accumulated blood or secretions that may lead to or be causing airway obstruction. Patients with severe head injuries who have an altered level of consciousness or a GCS score of 8 or lower usually require the placement of a definitive airway. Initially, the jaw thrust or chin lift maneuver often suffices as an initial intervention. If the patient is unconscious and has no gag reflex, the placement of an oropharyngeal airway can be helpful temporarily. Establish a definitive airway if there is any doubt about the patient's ability to maintain airway integrity. While assessing and managing a patient's airway, take great care to prevent excessive movement of the cervical spine with a cervical collar. When airway management is necessary, the cervical collar is opened, and a team member manually restricts motion of the cervical spine. Establish an airway surgically if intubation is contraindicated or cannot be accomplished. Breathing and ventilation. Airway patency alone does not ensure adequate ventilation. Adequate gas exchange is required to maximize oxygenation and carbon dioxide elimination. Ventilation requires adequate function of the lungs, chest wall, and diaphragm. Therefore, clinicians must rapidly examine and evaluate each component. To adequately assess jugular venous distension, position of the trachea and chest wall excursion, expose the patient's neck and chest. Perform auscultation to ensure gas flow in the lungs. Visual inspection and palpation can detect injuries to the chest wall that may be compromising ventilation. Percussion of the thorax can also identify abnormalities. Injuries that significantly impair ventilation in the short term include tension pneumothorax, massive hemothorax, open pneumothorax, and tracheal or bronchial injuries. These injuries should be identified during the primary survey and often require immediate attention to ensure effective ventilation. Every injured patient should receive supplemental oxygen. If the patient is not intubated, oxygen should be delivered by a mask reservoir device to achieve optimal oxygenation. Use a pulse oximeter to monitor adequacy of hemoglobin oxygen saturation. Blood volume, cardiac output, and bleeding are major circulatory issues to consider. Hemorrhage is the predominant cause of preventable deaths after injury. Identifying, quickly controlling hemorrhage, and initiating resuscitation are therefore crucial steps in assessing and managing such patients. Once tension pneumothorax has been excluded as a cause of shock, consider that hypotension following injury is due to blood loss until proven otherwise. The elements of clinical observation that yield important information within seconds are level of consciousness, skin perfusion, and pulse. When circulating blood volume is reduced, cerebral perfusion may be critically impaired, resulting in an altered level of consciousness. A patient with hypovolemia may have ashen, gray facial skin and pale extremities. A rapid, thready pulse is typically a sign of hypovolemia. External hemorrhage is identified and controlled during the primary survey. Rapid external blood loss is managed by direct manual pressure on the wound. Tourniquets are effective in massive exsanguination from an extremity but carry a risk of ischemic injury to that extremity. Use a tourniquet only when direct pressure is not effective and the patient's life is threatened. The major areas of internal hemorrhage are the chest, abdomen, retroperitoneum, pelvis, and long bones. The source of bleeding is usually identified by physical examination and imaging. Immediate management may include chest decompression and application of a pelvic stabilizing device or extremity splints. Definitive management may require surgical or interventional radiologic treatment and pelvic and long bone stabilization. Definitive bleeding control is essential, along with appropriate replacement of intravascular volume. Vascular access must be established. Typically, 2 large-bore peripheral venous catheters are placed to administer fluid, blood, and plasma. Blood samples for baseline hematologic studies are obtained when peripheral sites cannot be accessed. Intraosseous infusion, central venous access, or venous cut-down may be used. Initiate IV fluid therapy with crystalloids. All IV solutions should be warmed either by storage in a warm environment or administered through fluid warming devices. If a patient is unresponsive to initial crystalloid therapy, he or she should receive a blood transfusion. European and American military studies demonstrate improved survival when tranexamic acid is administered within 3 hours of injury. When bolused in the field, follow-up infusion is given over 8 hours in the hospital. Disability. Neurologic evaluation. A rapid neurologic evaluation establishes the patient's level of consciousness and pupillary size and reaction, identifies the presence of lateralizing signs, and determines spinal cord injury level, if present. The GCS is a quick, simple, and objective method of determining the level of consciousness. A decrease in a patient's level of consciousness may indicate decreased cerebral oxygenation or perfusion, or it may be caused by direct cerebral injury. Hypoglycemia. Alcohol, narcotics, and other drugs can also alter a patient's level of consciousness. Until proven otherwise, always presume that changes in level of consciousness are a result of central nervous system injury. Primary brain injury results from the structural effect of the injury to the brain. Prevention of secondary brain injury by maintaining adequate oxygenation and perfusion are the main goals of initial management. Because evidence of brain injury can be absent or minimal at the time of initial evaluation, it is crucial to repeat the examination. Exposure and environment control. During the primary survey, completely undress the patient, usually by cutting off his or her garments to facilitate a thorough examination and assessment. After completing the assessment, cover the patient with warm blankets or an external warming device to prevent him or her from developing hypothermia/warm intravenous fluids before infusing them, and maintain a warm environment. Hypothermia can be present when the patient arrives, or it may develop quickly in the ED if the patient is uncovered and undergoes rapid administration of room temperature fluids or refrigerated blood. Because hypothermia is a potentially lethal complication in injured patients, take aggressive measures to prevent the loss of body heat and restore body temperature to normal. Thanks for watching. Please like, share, and subscribe.